Well, welcome everybody. I'm excited to see everyone today and have this great topic today. I'm Courtney Valentine. Our other co-chair, Rachel Peds, is out today. So from both of us, thank you for coming. And I guess, Amelia, do you want to do kind of a member spotlight and introduction since
Sure, yeah. So we're doing this member spotlight now where we check in and kind of get a quick um, intro to see how people are using the PSIG and what they're doing in their different areas. So, hey, Liz, I'm just gonna pass it over to you and let you introduce yourself a little bit. I'm excited to hear about what you're doing in your role.
Well, thanks for reaching out. Can you guys hear me okay?
Yep.
All right. Good morning. I'm Liz Davies from the Montana Healthcare Foundation. Um, a little bit of an unconventional member spotlight because I am not a practicing BHC working in a pediatrics clinic, but I am an LCSW by background. And in my 60-second overview, I'll kind of let you know what we do at the Healthcare Foundation in this space and then why this SIG has been so beneficial to me. So let's see. The Healthcare Foundation was founded just over 10 years ago. We are the largest health-focused private foundation in Montana. So we have about $250 million in assets, which I always am reluctant to share that with folks who are always trying to apply for grant funding and other assistance to support programs. But it is a very awesome, privileged place to be able to support the work that's happening with foundation resources. So our charitable activities include direct programming like leadership development and policy research, as well as grant making through 11 strategic initiatives. And annually, we also do an open call for proposals where we're able to make responsive grants to projects outside of our initiative areas. So I lead our integrated behavioral health initiative, which has been working since 2017 to advance. Sorry, I'm looking at my notes on my other screen. To advance behavioral health integration in primary care across Montana. We provide grant funding, implementation support, and training and technical assistance to clinics across the state. And to date, we've supported 68 primary care practices, which includes all 11 of our large hospital systems, about 3/4 of Montana's critical access hospitals, all 13 of our federally qualified health centers through a network grant to our state's primary care association. We awarded them a grant. They built kind of an integrated care academy to support their FQs with training and TA around IBH. We've worked with 3 of our 5 urban Indian health clinics, 3 of our 8 tribes, and 2 independent pediatric practices, which we really started funding in 2021, kind of after the Surgeon General's declaration of the youth mental health crisis. So we kind of expanded our eligibility criteria for grant funding and opened it up to independent pediatric practices. So as of the end of last year, about 80% of adult and pediatric Medicaid beneficiaries in Montana have access to primary care in a clinic that we have funded through our initiative. The type of integration that our sites use really varies. We recently completed a year-long program eval and learned that IBH looks very different across these settings. I would say the FQs, the urbans, and the large hospital systems are the most advanced in terms of having a culture of leadership support, physician champions, robust staffing, and more advantageous reimbursement rates. Our rural health clinics are more impacted by the workforce challenges that I know face all of us. Inadequate EMRs and IT infrastructure, that's been a real barrier to advancing integration, and then just lack of capacity, generally speaking, with the existing staff and resources that they do have, just being stretched so thin and wearing so many hats. Despite this, over 75% of our sites do have access to behavioral health care. Most of those have embedded behavioral health providers in their practices. Many practices use a hybrid model, so doing some co-location and integrated care, and some are starting to offer blended services So thinking about that as maybe a blend of PCBH and collaborative care. And I've gone definitely over a minute, but what I get out of the SIG, what I hope to get out of the SIG is just best practices for working with kids and adolescents that I can share with our grantees. They're always hungry for this information, and many providers are coming into primary care for the first time, maybe out of specialty mental health or just recently completing a master's program, and they may have not had a ton of exposure to working with this population. So I get tons of awesome ideas from you guys and the base camp materials. So thanks.
Thank you so much. And thank you everyone who's just joining in. I know we had a lot of emails about difficulty logging on. I think this is going to be hopefully the first month of figuring out this big switch, and then hopefully next month it'll be a little easier with the passcode. So I appreciate everybody sending messages so we can get everyone on. And I guess, do we want to move to the research corner then to get started?
Sure. All right. Well, hello, everybody. Nice to see you all this week. Happy 4th of July. And I hope you're having a good summer. Let me just, I don't want to give away all the good stuff today, but I'll just give a little introduction to our topic on early relational health. And let me just give me one sec. Share. All right. So I'll briefly review an article on the paradigm shift to early relational health, a network movement. I encourage everyone to read the full article for further information. I'll just kind of gloss over it here. So the COVID-19 pandemic, economic challenges, and heightened awareness of racial justice have spotlighted this importance of parents providing safe, stable, nurturing relationships for young children. This has prompted a renewed emphasis among child health providers on developmental science, advocating for advanced team-based care, co-designing services with families and communities, and promoting equity and anti-racism in healthcare. The American Academy of Pediatrics has signaled this paradigm shift with a 2021 policy statement urging pediatric care to prioritize safe, stable, nurturing relationships to mitigate adversity and foster resilience, aligning with initiatives from the Harvard Center on the Developing Child. Early relational health, ERH, builds on knowledge from fields like infant and early childhood mental health and neurodevelopment, emphasizing the crucial role of positive relationships in child development and well-being. ERH highlights relationships as foundational vital signs in pediatrics, promoting health and resilience starting from infancy. It also emphasizes the influences of community resilience and social, economic, racial, and cultural contexts on family environments. ERH advocates for systemic changes to support families, addressing both individual challenges and community-level factors. Infant and early childhood mental health focuses on the developing capacity of children from birth to 5 years old to form secure relationships, manage emotions, and learn within their family, community, and cultural contexts. It underscores the importance of nurturing and consistent relationships for children's mental health. Therefore, these practices are relationship-based, culturally responsive, trauma-informed, applied across various disciplines to promote healthy development and address mental health challenges. ERH can complement these infant and early childhood mental health by expanding its focus on prevention and promotion, drawing on neurodevelopment and child development science. ERH emphasizes the pivotal role of relationships, particularly between parents and infants, in fostering mental health from the earliest stages. ERH aims to enhance awareness and support for infants' mental health needs amid challenges like COVID-19, advocating for essential relationships as a cornerstone of public health responses. And therefore, leveraging ERH can broaden the scope of interventions and workforce development, benefiting from lessons and principles to effectively support infants, young children, and families. The Early Relational Health Coordinating Hub established these strategic priorities to guide activities for the next 3-5 years. I'll briefly touch on them. So strategy 1, parent leadership as a key equity strategy, and that is listening to voices of families about their hopes and dreams of their young families, the role of the child health system, supporting services, making it so families feel respected, heard, and not judged by child health practitioners. Strategy 2, advancing ERH across place-based early childhood community initiatives to allow for greater collaboration between child health systems, public health, communities, and families. 3, technical assistance resources for communities and providers. Multi-sector and cross-sector workforce development, how healthcare settings can contribute to the child's and family's relational health while recognizing the importance of social connections, supports, and interactions, overall child and family health. Measurement, research, and evaluation to increase the visibility of research, measurement tools, and evidence-based practices. Policy advancement to advance equity, support economic security and mobility, train providers serving families using evidence-based interventions to develop a diverse and well-trained relational workforce, and to increase access to services and strengthen early childhood systems. And last, widespread messaging and dissemination of early relational health. A new focus on relational health in early childhood shows great promise for improving the well-being of infants, children, and families. It's crucial for the U.S. to create supportive environments and safe, stable, nurturing relationships that offer hope, promote health, protect from challenges, and help heal trauma and stress. Therefore, prioritizing early relational health can lead to significant changes in how services are delivered, how funding is structured, and the overall outcomes for generations of families. And again, please check the article for further information on this topic. And thank you.
All right. Thanks, Jonathan. I'm really excited to introduce Mary Virginia Maxwell. MV is amazing. She's done all sorts of fantastic things. But right now, one of her passions is working on early relational health. So I'm excited to hear what she has to say about that. She currently works in our Birth to 5 program through ESD 105, which supports our school districts here in Yakima.
All right. Good morning, everyone. I can share my screen, right, and pull up my little slides to keep me focused. Awesome. I will do
Please
that.
do.
But yes, yeah, thank you, Amelia. I'm MV. I am licensed mental health clinic. I was one of the first integrated behavioral health people at Yakima Peds, so got to stay there for 12 years, and then decided for whatever reason, I guess, to head back and start looking at our littlest people. I think from working in the teen health clinic where I realized, I wonder if I had met these people earlier, you know, what we could have done different in a more proactive, promotional way as in kind of promoting health within the family. So I will come over to my little slide deck here, and thank you for allowing me this opportunity. And let's see. Okay, finding everything. Here we go. Let me know if you can see it all. It's awesome because now I won't be able to see you guys.
There it is. We can see it.
It's good. All right. Thank you, friends. Right. Thank you, Jonathan, for that really quick, kind of in-depth review of that article, which is long, but really interesting. But we're going to try and break it down a little bit to make it more accessible and see if you guys can locate the same energy and passion I have for working with our littlest. I think my oldest child, it just turned 40, and I was reflecting when he was born. So this is 1984. Doesn't seem that long ago, but I remember they wanted to know if he wanted to get circumcised. I was a 20-year-old with a newborn. And I said, well, that sounds like, what is it? And they're like, oh, don't worry, babies don't feel pain. And I thought, babies don't feel pain, because they just poked his heel, to get the early blood test. And I was like, he didn't seem to like that. And they said, no, they're not all connected yet, all their little parts in their brain and body. So don't worry, babies don't feel pain. And this is how we do it. So I decided not to do that. That was my first time, though, of kind of realizing, do we think of babies as just this completely different, not quite fully human entities? And what could that look like for us? So let's go on. So yes, Jonathan's done a great job already of defining early relational health and IE-CMH work, but I was going to bring into this conversation a tool, the DC 0 to 5, which can help us do this work intentionally and accurately, right? And effectively in our clinics, and then some resources for you guys. So again, we just defined what early relational health is, but it's just really recognizing that the first 1,000 days of your life can really have a profound impact on your worldview, how your system is organized, and really the quality of the relationships that you are involved with, from your caregivers and caretakers to your early child cares and preschools. And so that is where I get to work right now in our community child cares, our Head Starts, early Head Starts, our ECAP programs, and all the way up through our kindergarten classrooms. And of course, universal early identification of what's going well in relational health and what might be causing a little bit of concern or problems could add value to our care. Again, this idea of infant early childhood mental health is really still kind of new to a lot of people. And so just recognizing that time is so crucial to forming the human being that you're going to be. And I love that when I talk to educators and early childhood educators about this, really it can help also protect our workforce, right? You probably are well aware of the fact that many of our early childhood educators, one, they're not paid enough, but also it's really difficult work right now, certainly since the pandemic and before that, but the pandemic amplified, I think, some of the issues that we see. So helping to recognize what might be going on with what we see as challenging or problematic behaviors. And then also making sure that we don't have this sort of marginalized population, which in our community here is very much on our people of color. You see a higher rate of suspension and expulsions in our early child cares, preschools, and in kindergarten. I remember when I first was talking to the doctors at Yakima Peds about this, they're like, that's not a thing, that's not happening. I was like, no, it's happening. It continues to happen. So recognizing that this can be a powerful force to work against that. So just recently I presented to a statewide group of family medicine doctors, and I always, probably this is a bias I need to check, but I just assume doctors have so much wonderful information. They've had such wealth of trainings and knowledge, but they were just shaking their heads at me and they're like, this is brand new information to us, we need a moment here. So again, just recognizing this might be really new concept to us, that little people have intense feelings and an 18-month-old can be depressed or have anxiety, then we need to think about this. So we know age-appropriate assessment and diagnosis, and it's going to look very different with our youngest people because often they don't have a voice. They don't have a way to tell us very clearly. I don't know if you've ever hung out with a lot of 5-year-olds. While they certainly will tell you lots of good information, they cannot often articulate their innermost feelings around how things are being processed within their systems. So in Washington State, we're so fortunate in that we are such a kind of front runner in this, but we've actually created some policy to support using the DC 0 to 5, which is the Diagnostic Classification of Mental Health and Developmental Disorders of Infancy and Early Childhood. And I know in my integrated behavioral health work, you have that very short time to kind of understand, through your contextual interview, what is going on, what am I looking at? And what I appreciate about this work right now is it gives me a moment to step back and say, I don't know what I'm looking at for this moment. And I really need to sit with this for a moment or get multiple times to observe a child. So I love that this work allows us up to 5 observational periods to make a diagnosis, right, in different settings in Washington State. I'd be curious right now, maybe raise a hand or put it in the chat. How many of you are aware of the DC-05 or use it in your work currently? Maybe Amelia, you could tell us what I'm looking at.
Yes, I will keep an eye on it.
Oh, thank you so much. Because of course I was not familiar with this resource at all, as a mental health provider. So really what they decided was we really needed some way of recognizing, that it is different when we're assessing very small people, and it's certainly within the context of the relationship, right? And so they got together, 0 to 3, of course, printed this out and designed this, but they got together this sort of idea of the practitioners, those of us in the field, let's say this is what we need, researchers that are looking at all the research behind it and what is available to us. And then they tried to find some sort of balance there, right? To make it clinically meaningful and empirically derived. So if any of you have seen it, here is a DC-05, which just really helps us to organize our way of approaching families, right? and looking at what we're looking at when we're looking at small people or struggles within that family system. It's a multi-axis classification system. And those of you who are more recent clinicians didn't really ever have to deal with this, right? So those of us back in the early DSM days. But it's a very descriptive approach to classification. I love that it has a real emphasis on a culture, and then really helping us understand developmental competencies, right? And I've found a very helpful way for me to organize what I'm looking at and what I'm understanding, and also to allow for it to shift and evolve as we know it will. Here are some states right now with legislation or policy endorsing the use of the DCO-5. I think the language in Washington State made people a little hesitant because it said must use, and I don't know, lots of people don't like being told what they have to use, but it is a very helpful book for this work. Again, it is a comprehensive process. It's relational and family focused. To me, this all seemed very much my BHC work, right? Contextually grounded, culturally informed, developmentally specific, and it is strength-based. Hurrah, our medical models, often just still are very much in a deficit space, right? This is how they were evolved. So when we're looking at those developmental concepts, when we're coming into contact with a little person and their family in the clinics or wherever you practice, we need to kind of hold in mind, perhaps, emotional and social capacities are present at birth. They serve as the very foundation for all development, right? And then those earlier capacities are needed in order to reach higher levels of functioning. One of my little bits of information I picked up along the ways in my last couple of years studying this at the University of Washington Barnard Center is there is only one muscle that a newborn infant can voluntarily control the minute it's born. And what do you think that one muscle would be, you guys? You can just take some guesses. We'll come back to that. Amelia, tell me if someone has some ideas around that one muscle that they literally
mouth. Someone said mouth.
Nope, not the mouth, but close. You're in the right
Swallow.
area.
Someone said swallow.
Nope. Those are reflexes still. This is voluntary control of a muscle.
I don't know.
Okay, I'll just tell us so we can go along. It's their eyes, right?
The eyes. Oh.
And think of how powerful that is. Why would a little tiny baby need to have control of their eyes? Because of course they are completely helpless. They have arrived onto the planet and they are hoping your eyes meet their eyes and you get it, right? You see they are helpless. You are going to be there to meet all their needs and protect and care for them. I just thought that was fascinating. So we see this, right? We walk into a room and sometimes we've been pulled in there due to the physician or someone has already reached out to us. But here are some red flag emotional or behavioral patterns that we might want to keep in mind. Anything that's unusual for an infant or a young child. I love this one, cause parents or others to see the infant or young child as difficult. And here's where we really want to get into that family culture or other ideas of what is difficult behavior. Make interactions with that infant or child difficult to sustain or to have, are seen in multiple settings by more than one person. They persist. Cause distress or impairment to the infant or the young child and family. I often think about anxiety in very small people. And sometimes I've approached it to families and the parents will say to me, well, we don't see it as much anymore, but of course, we never leave the house. We don't take her out with us to restaurants or supermarkets. We only have one babysitter, and that's my mom that she feels comfortable with otherwise. But really, we think her anxiety is better, where you just see the whole family has kind of come around in a obvious way of loving concern to help, mitigate these symptoms we're seeing of anxiety, but actually it's still there, right? We just are not addressing it or just seeing it because it hasn't been sort of poked at, right? And they're outside, and if any of the behavioral patterns are outside the wide range of age-appropriate or cultural norms. I don't know in your communities, but my number one referral right now is for ADHD type behaviors or autism type behaviors. That is what I'm seeing in my early centers and in the preschools and kindergartens. It's not always that, right? And then when I think about this work within our BHC, in our primary care clinics, you think obviously we're going to use, that first we're going to lay that foundation for physical health, right? because all aspects of an infant or young children's lives are interrelated. Physical conditions may influence mental health directly, indirectly, through the caregiver environment. I had a child that was born with what they told me was a hole in their heart. That's all I heard. I didn't hear the actual diagnosis because my brain started racing. And the way I tended to that child was very different than if I had had a child that was not born with a hole in their heart. So listening even to how the parents describe the illness to you, right? So the DCO5 gives you a nice list of health domains, really listening to those parents' description of how they understand the illness, and then communicate with the health providers involved with that family. And then we also look at psychosocial stressors. Of course we do, right? Social determinants of health. And we know they might influence the presentation, course, treatment, and prevention of mental health symptoms and disorders. They often co-occur. Here are some of the ones that we list out in the DCO5. Challenges within the infants and families primary support group, challenges in their social environment, educational or child care challenges. I would say after ADHD, autism, the #1 referral I get is my child is getting kicked out of their childcare or preschool or kindergarten. Can you please help me? I'm going to lose my job if I have to continue to respond to this, or I don't have childcare. Housing challenges, economic or employment challenges, infant young child's health, legal or criminal justice challenges, all the others I know you guys probably most likely screen for. But here's where I think the DCO5 really helps us understand what we're looking at when we start looking at that relational context within the primary caregiving relationship. We really know then that child is going to develop a sense of trust and expectation of the safety in the world, and the child needs this to develop optimally. One of my mentors at the UW, Dr. Nisha Isarong, you might have heard of him, but he always reminds us to think of the 4 S's: safe, secure, seen, and soothed. And I always reference that back to young people, but he always reminds me, that's everyone in B. That's not an infant or a child. That's all of us who need this. So the 4 S's. But really, when we're looking at relationship specificity, and you might have seen this within your clinic where grandma might bring them one time, or auntie, or then mom or dad, and you have a very different feeling for what's going on with the child and with the description of what the issues might be. So that relationship quality between the mother and child, between the father and child, any other caregiver, right? Certainly we are working very hard to help our early childhood education workforce understand this, right? And kind of be able to look, and same as all of us are doing, pausing and being curious and thinking with compassion about what might be going on, and even being very intentional with our language when we describe children, you know, as a quote, a behavior kid, or a child, I get a lot of, well, disrespectful or lazy. You know, tell me more of what that looks like to you, right? Because that is going to be obviously coming through our own lens and experience. So really, when we're thinking about the relational context, we're really thinking of that caregiving dimension. And how does the family or the other caregivers know and value the child as unique when you think of their own little default system and how they show up in the world, everything that they have there? You know, how is that viewed? Is it viewed as difficult? Is it viewed as adorable? You know, what is it? So we want to see what they can share about their child, right? What's going right with this child? What just makes your little heart light up when you see this child? If the parents or the caregivers are emotionally available, right, to that child, are they able to monitor the child? Are they able to read the cues effectively and respond effectively? And does the child have cues that are easy to read? You know, sometimes we can have a mismatch there. I remember once meeting a very young mom, a 17-year-old, in the clinic, and she had a 4-month-old, and the child was very quiet, sitting in their car seat still, and mom was sitting, and she said, "My baby hates me. I just know my baby hates me." I thought, well, tell me more. Obviously, what do you mean? And what was happening was the baby just had a really kind of slow, low affect. And mom was seeing that as not engaging. And then when baby would kind of amp up because mom had missed some earlier cues, then baby was angry or upset. And then mom didn't have effective ways to soothe baby. And they had all this tension going right there. And you can imagine, as a very young person having a child, you might not have preparation for that, or every baby is new, right, to you. So depending, it doesn't really matter your age, but, you know, just not having an understanding of that. So I'm fortunate within our schools to work with our adolescent, pregnant, and parenting teenagers as well, to kind of give this information. I can tell you they are very hungry for this, and they are very interested in learning more all the time about how they can most effectively parent. And oftentimes parent differently than how they were. So again, this all helps us within the caregiving dimensions. And are they comfortable and completely in charge with this role of being a parent, right? It definitely would overlap with your own emotional availability, right? So this idea of like, is this baby doing this to me? Is this baby, does it feel intentional and purposeful for this baby to continue to interrupt and where I'm not getting my needs met? And am I able, right, to set my needs aside in order to meet the child's needs? And then again, does that parent have the support they need in order to do that? Right? You know, and that is an always shifting place to be, all right? But you do have to have some understanding of where baby is coming at you to understand, to be able to respond effectively. So again, you know, the DCO5 also gives us these lovely ways, a more, I think, descriptive way of understanding different disorders, ones that we are commonly seeing these days, right? From neurodevelopmental, sensory processing, anxiety, mood, sleeping, eating, and crying disorders, how trauma, stress, and deprivation is layering into that, right? And then if there's just some sort of problem within the relationship that we need to talk about and see how we can be helpful. So again, and I like the way the Axis 1, that's the very last thing you go to, right, using the DCO5, and that you've already gone through all of this information, right, so that you get to your idea of what the diagnosis is after really looking through everything else very carefully. And here in Washington State, as I said, we have up to 5, you know, times to assess to really come up with that diagnosis so we can make sure that we can get as closely to what is appropriate as with information that we have right now. And again, I'm always thinking about, well, children can only be as healthy as their caregivers. I'm not sure where you are practicing, but I know here in our valley, we have lots of challenges within social environments. And so always keeping that here. And often when I'm presenting to people, there is a little bit of this, does this feel good to do early identification and intervention? Do I want to be identifying a toddler with ADHD type behaviors? You know, there's a little bit of like, are we just, you know, pathologizing this? And we really, there is where we want to be really, I think the DCO5 helps us be very careful in understanding this. So one, we know early identification interventions can literally resolve symptoms. I was mentioning, I think earlier in a conversation to Amelia, one of the referrals I got from a VHC was a child who'd been kicked out of 2 childcares and was on the verge of being kicked out to the next one. I was able just to do one quick conversation with the parent and move this child to a different childcare, an ECAP program that had more robust training, better ratio of students to caregivers in the classroom, and just a different setting. And all the behaviors disappeared, you know, because it was very specific to those environments that the child had been in and wasn't able to access these other quality childcares. Not that these were terrible, it just, it was a struggle there. And so I thought, well, now that's interesting. If all the symptoms of these very challenging behaviors immediately disappeared in this other setting, that is good for me to know, right? And I love that this gives us a way in to have a compassionate, you know, what's going well for you, where your struggles are, support for the caregivers, really by understanding and keeping early relational health right in the front of our minds. And then, of course, we're able to collaborate with other providers. I can be the eyes in an early learning center and come back to Amelia and say, hey, this is what I saw when I was in the classroom. This is what's going on. And then we can also use that shared language and understanding, right? So some of those missteps are not happening as frequently. And then if within your area you have a local infant early childhood and mental health workforce, jump on board and, you know, help us out here. I really do feel like this is such a helpful way of working with families and our children, right? In order to really resolve symptoms and get an understanding of this in a very, it just feels like a very compassionate place to be. And that might just be that, you know, young children, you know, kind of tug at us a little bit differently sometimes. You know, we're able to still reframe stories and understanding of behaviors. I'll give an example. I walked into a very challenging childcare, just they have a high turnover rate of staffing, lots and lots of children with significant trauma. They receive a lot of children that are new to foster care systems. And so just can be often a little chaotic and overwhelming. And I walked in the classroom to observe a little person that had been referred to me through one of our farm workers clinics, I believe. And I didn't know him, but he saw me and he jumped over to me and he jumped onto me And he just said, you know what? Read me a book, bitch. This is what he said to me. Now, immediately the teachers in the classroom were like, oh, we don't say that. Oh, no. But I was thinking, well, maybe this is just a term of endearment. I was just trying to go with, I don't know this child at all. So of course I responded to like what I thought was possibly the emotional need, the ask that was underneath that was, which was, I'd like you to sit down with me on the cozy couch and read a book, which we did. And it worked out very well, right? And I understand that we would obviously address that language at another time, but that time was not the time to address the language. And he and I became very close collaborators in the classroom and was able to support him into kindergarten and his family. And things are definitely going better. And that was sort of a common way of speaking within their family. And it did turn out. So yeah, so, you know. So again, this model, I think that this model is very strength-based, looking at those positive relational experiences. And we have different models that are being used now within pediatrics and other settings. If you're familiar with the HOPE, right, framework, and here's a lot of words on, this is one of my little grandbabies. I've permissioned to use them because they do remind me that I have a reason to keep doing this work right now. But I really love this quote from Dr. Alicia Lieberman: cultivating a frame of mind where experiences of joy, intimacy, pleasure, and love are considered to be as worthy of therapeutic attention as negative experiences. So I really love that as I hold that close when I move into a space with families. Here are some more resources for you that are different ways they are looking at moving this into pediatric clinics or other settings. So I thought that might be helpful for you. And I think that's all I have for this morning. I know I speak quickly because I always feel like it's going to go, my time is limited. But
no, that was wonderful. And when you get me the slides, I'll make sure we get them out to everybody so that y'all can have a copy of all those wonderful resources. But let's kind of just open the floor up. Do you guys have any questions for MV that you'd like to ask?
I am curious if any of you have a DC-05 on your desk, or has it floated across your frame of reference?
I took the DC 0 to 5 training. It's probably been a couple years now. So yeah.
Wonderful. Here in Yakima, we are partnering with Heritage University, and we have now a master's in social work program and a master's in mental health counseling. And so we are going to be putting a little bit of emphasis on that as well to get it into the hands of our newest clinicians, and hopefully they might be interested in this work as well. Yay, thank you, Rachel. That makes me so happy.
I guess one question that I might have is there like one like small thing that like behavioral health providers in integrated care settings can do to kind of like start this work? Maybe if like the whole work seems really big, is there like one small step that we could start taking to kind of integrate or use this kind of stuff?
Yeah, well, I think going to the 0 to 3 website or your local state infant early childhood mental health website would be useful as far as being familiar with sort of the context of this. I think some in Washington State, the trainings for the DC-05 are free, even just the short one. I think another resource maybe I'll pop into the chat or send to you, Amelia, would be the FAN, the reflective tool. That can be really helpful when you're kind of processing, what did I just witness in that room, right? What was that about? And I think the number one thing, if you could go into a small room, if you notice any moments of connection, any of those little joyful moments happening, call it out and name it, right? So even lots of times by the time small people have been referred to us, all the wheels have come off the bus, and the family comes in with a laundry list, right? Of like, oh my gosh, this is what's happening. He doesn't listen, he doesn't eat, he runs around the room. Child, meanwhile, is bouncing around the room, doing what they do. But being able to stop and find those little moments of like, oh my gosh, reframing that he is such a creative advocate for his well-being. I love that he is able to tell you exactly what he needs and wants right now. And then maybe, noticing where they are, as far as being able to respond to that. That's what I found really helpful within those brief moments, right? Of just coming alongside a parent and being able to, one, see them through their eyes, but also see what's going well, because it can sometimes feel so overwhelming, I know, when things are really challenging. Also working really hard, I think, to remove the stigma around any sort of diagnosis, early diagnosis, in that the idea here is sometimes we need that diagnosis, especially in school districts, in order to get the services that you're going to need and the early services that you need even before school. So I love being able to reframe that to parents. Yeah. Yes, thank you. Okay, I've got a question from Maria. So we have connected with our HCA, right? And so they are the ones helping guide this work. So they are running the Medicaid reimbursement. Travel is being paid for once, right? Because you can imagine if you and I are zipping around the Yakima Valley, going and observing children in other settings, and gas is $5, you know, it's like, okay, do I want to do this? So right now, you might look at your local HCA and how your Department of Health, if there's any initiatives or programs that are funding for that right now. So we do have that. Again, we're in a really privileged place. We had legislation pass in 2021 with a focus on the Fair Acts for Kids, with a focus on getting this work done, recognizing the importance of early recognition and supporting families. I mean, we know it all makes sense, no duh, of course. But yeah, if we can't do it and get paid for it, then how do we do it? So right now, my work is funded under a grant through SAMHSA, but then also with the idea that it is all sustainable using, you know, that I can bill. We here in Washington State, I can bill for those 5 sessions before I come up with a diagnosis. So that's here, Washington State.
You were kind of mentioning the stigma around a diagnosis and trying to like shift that, which I think is beautiful. Have you noticed the opposite, where like a parent just wants a diagnosis, but really like there isn't? Or like, how do you speak to that, I guess, would be an issue that I see sometimes.
Yes, agreed. Yes, we do see that sometimes. And then, you know, again, getting curious about, tell me what you see and why you think it might be that way, right? And being able to break it down a little bit, because ADHD and autism, you know, since there's no blood test, you know, we're really looking on observational data, right? And meeting those criteria, you really do have to kind of break it down a little bit. And it's sort of this movement of, well, everyone's a little bit autistic. I'm like, I don't know about that. You know, I understand where it was coming from, where the heart was coming from. In the evenings, I work in an autism community for social skills, and also just for hanging out. Whether you're on the spectrum, off the spectrum, or whatever, just come on down. And so just really listening to those friends talk about their experiences now that some of them are in middle school, what it was like being a small person with a true autism diagnosis, and then some of our others. So I think being curious with the parent of, you know, I think you have to acknowledge, obviously, and validate their concerns, right? And then see if you have something that can, again, notice those times when you're seeing those beautiful skills of connection or reciprocity, right? Or enjoyment of play, or things that are, you know, we might be a little bit more trained to notice in those moments, right? Versus the information you might be getting off TikTok videos, which still happens. I have lots of families getting lots of information from things. Yeah, so. But valid, I would never step in saying, well, that's not what I see, right? We just want to absolutely be like, I'm so glad you brought that to our attention. Let's sit down and look at this together. Let's go. Here we go. I'm fortunate in that I have a young son that was diagnosed with autism in, let me think, 1996, back before we had Centers of Excellence. And he had no language and really difficult behaviors. He was the child that if I was in the market with him, someone would come up and say, you need to discipline that child, da, 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 you know, this sort of old school way of thinking. And then I was so fortunate to get him into a program. But watching him navigate life, you know, and he needed just low levels of support all through school, but just watching him navigate that has been very part of my lived experience on the planet, obviously. So enjoying him now. I always enjoyed him, but not always when he was flipping out at the safe way. And I had 5 others I was trying to get through the line. So
what other questions people have?
I'm curious, I guess, as you keep bringing this up, I keep thinking about more ways of earlier intervention and prevention, and thinking about a clinic where I work at where we have, you know, lifespan. So thinking about how could we better support our pregnant parents? Or how could we be kind of putting in preventative or psychoeducation earlier on around the 0 to 3 or 0 to 5? Do you have any resources or thoughts on things that we could do with adults and not just the children?
Yes, absolutely. Thank you, Courtney. Well, here, again, where we work, I have access to maternal home health visitation, parents as teachers, the nursing home visiting program. Promoting first relationships is an evidence-based curriculum that they're trying to roll out more in pediatric clinics that really brings us up, and in OBGYN type arenas. So I think yeah, starting that conversation early is really important, right? If you even think about, if any of you have ever been mothers, or met young mothers, just how that remarkable shift in how you view yourself and how you're going to be walking through the planet now is huge. And so, recognizing that's something you can discuss, and how are you with everything that is going on, and what does this bring up for you? I know in our short sessions that's not possible, but the different programs that work with prenatal through the first year are really helpful to have that person to come alongside. I know in our hospital, we have Eat, Sleep, and Console now, right? Also another evidence-based program so that parents that might have been experiencing substance use, people respond very differently to them. Thank goodness. So just looking at all those different ways of supporting. But yeah, I think just holding in mind, that as much as having an infant is a joyful, wonderful thing, it's a complex time, right? So, and I think, again, our young mothers are sort of inundated with a lot of information. And this is the most wonderful thing ever and all of that. And maybe you're not feeling like it's the most wonderful thing ever, and having a safe place to have those questions. So I will definitely send the FAN paperwork with you. It's a very scripted little tool that you can take with you into every room you go into. That might be helpful for this too, Courtney.
Wonderful. Thank you so much.
Awesome.
And Promoting First Relationships was developed at the University of Washington Barnard Center, and they are updating all their materials, and they have them all now in Spanish. And I believe they're just kind of figuring out what other languages to highlight for that. And I will send you that link as well to get some of those materials. And it's just, oh man, some of their little handouts. Not that I love handing people handouts, but they're very nice graphics and very to the point, and just really help guide some of those intentional questions. Also, I can't help but also promote the Vroom app. Anyone in here still use the Vroom app? Right, yeah. Still good stuff, right? Yeah, so there is something that you can say, look.
And they helped with Keystones too, which I feel like has some good, cute parent videos, which I really like, and parents seem to like them.
Yes, yeah. Yeah,
for the first 3 years, I think, of life, maybe.
Up to 3?
I think it's up to 3. I think it goes up to, yeah.
Yep. I think the videos can be really helpful, right? And Vroom is in Spanish as well, so for our community, it's on point. So, yeah.
Any other questions before we kind of wrap up a little bit?
Oh, and I'm happy, Jada, you'll be working with more little people. So feel free, anybody, to reach out to me anytime. As you can tell, I love to talk about this. Oh, curious about chronic fatigue in youngsters. Ooh, I'm going to send you a really good little set of information, David, that I just got from Seattle Children's around that. So yes. And I would, again, doing your contextual interview, thinking about chronic fatigue, if you've already ruled out all the physical, right, tests, you would want to think about the quality of their sleep. And I think what I'm seeing right now in some of our families is they're still underestimating how much sleep a child needs, and the usefulness of, maybe they won't nap, but rest times. And then, of course, we always, are interested in screen time, how much is being used and at what times. And again, not shame or blame parents ever, just like, oh, what else can we offer you to make sure that you feel supported in responding to your child's needs and delight in them outside of that time. So look at you. Thank you, guys. I'm putting everything up. So I'm making some notes here of what to send you, Amelia, okay? that I can
Wonderful.
find
Thank you.
resources.
Yeah, we'll get
And
those
you'll
on
make sure
Basecamp.
folks get them.
Yep, we'll put them up on Basecamp for everybody.
Thank you.
Yes, everything will be on Basecamp, and obviously this will be recorded and posted. We always want, if anyone has any job openings or other things they want to promote for our team and others, please, you can message anyone on the Peds leadership, or also just post onto Basecamp. We will make sure it gets there, and we want to keep encouraging that great sharing. Also, next month, we're very excited to have Dr. Patty Robinson going to be doing an hour-long talk about FACT for pediatrics. So it will be a wonderful next meeting. It will be August 5th during a normal meeting time. So please put that on your calendars to come attend. It'll be a wonderful, I think, intro to how we can all use FACT within our visits with patients. And any other topics that you are interested in, someone that you think would be a great person to present to the group, any other topics you'd be interested in hearing or resources, please feel free to keep sharing with us. We would love to keep getting more people to do our member spotlights and continuing to expand on the topics that we present here for this group. So thank you so much, Mary Virginia Maxwell. It was wonderful to hear you talk about this topic, and thanks for everyone for joining us today. Have a wonderful day.
Bye, guys. Have a great day.